Hi, this is Professor Cornell again. We're talking about fluid and electrolytes part two, and this is the second video. So we're going to just dive right in now to risk factors. We talked about these last semester. This is a slide from that. I just wanted to go over the why are the very young and the very old at higher risk. And remember that the infants very young are their body weight's 80% water, and the very old, their body percent weight is 40 to 45% water. So it's much different than an adult. And for the very young, their kidneys are not yet fully developed. Their metabolism is higher, their respiratory rate is higher, their subcutaneous fat tissue is lower, so they lose fluid through their skin. They're breathing faster, so they're going to lose fluid or moisture through their breathing. Um, their kidneys are immature. I may have already said that. Anyway, so they're not able to hold on to fluid as well. For the elderly, their kidneys, even if they don't have kidney failure, they still aren't quite as responsive to ADH. And so their natriuretic peptides are higher. So they tend to lose water more easily than non-elders. And they have more comorbidities, especially heart failure and kidney failure, chronic. And they may be incontinent and trying to manage that by not drinking. For both elders and babies, they may not be able to when they do have a thirst mechanism kick in, they may be unable to get fluids for themselves. They're dependent on another person. So that can be make them at higher risk. So the other things mentioned here we talked about last semester, certain medications, overuse of laxatives and antacids, and then if they're on steroids. Okay, so these are the common blood tests that you need to know for fluid and electrolytes. We talked about these last semester. The BMP is one of the most common labs that's drawn. You need to know the normal values of the sodium and potassium, the BUN and creatinine, and the glucose for your NCLEX exam. For me, I want you to know sodium and potassium. Whoever instructs you on kidney diseases are going to want you to know about normal ranges for BUN and creatinine and glucose for diabetes. Chloride and bicarb, you're going to need to know when you study acid-base balance more. The normal ranges for all these labs have a little bit of variation depending on the lab. Um, so just to know that, I want you to use the normal labs that are in the book. This is a urine dipstick, and you've probably seen these in the nursing homes that you've been. The reason I have it here is because it has specific gravity on it. So normal is 1.01 to 1.025. So anything above that would be the urine is very concentrated, and under that would be the urine is high water content, less concentrated. So this just gives you a hint of what's going on with their hydration status, possibly. The complete blood count. This is another very commonly ordered lab. So the four ones you need to know are white blood cells, hemoglobin, hematocrit, and platelet count. And the hematocrit and hemoglobin for fluid status will um, give you a clue of what's going on with the patient's fluid status. If it's high, it may mean that they are very concentrated. If it's low, it may mean they're diluted, which would be fluid overload. Oops, that was a fishbone for the H&H and the CBC. This is serum osmolality. So a normal ranges for serum osmolality is 270 to 300, and it tells you the ratio of water to the chemicals that are dissolved in the water, the particles. Because of the law of osmosis, water will cross the membrane, cross a membrane to the higher concentration. So this is important when we're talking about IV fluids or when we're talking about edema. There's a lot of other aspects that it's applicable. Um, Knowing that wherever there's more concentration, so if your bloodstream and your interstitial spaces are more concentrated than the intracellular space, then that's going to pull fluid out of the cell. And if it's vice versa, if the blood and interstitial space is low concentration, that's going to pull water into the cell. So that's another blood test that can give us a clue of a person's hydration status. So this is your flip assignment that I had you do. You need to know this for your test for NCLEX, but most importantly, you need to know this so that you can recognize when your patients have signs and symptoms and what it may indicate. This is the excess. You did this since we're doing a lecture on video. I'm not going to go over these. I just that you need to know this information. Let's do a comparison though of the different for a deficit to excess. So sometimes you'll hear deficit called hypovolemia, meaning low blood volume, and you'll hear excess called hypervolemia, meaning high blood volume. You also may hear people say fluid overload, which is excess, or you may hear people say dehydration, which is deficit. So you'll see those words used interchangeably. Now, what changes would you expect for a deficit in the cardiovascular system? Heart rate, you would expect to go up. Blood pressure, you would expect to go down. Peripheral pulses are going to be weak and easily occluded. Neck and hand veins would be flat. For excess, you would see the heart rate also go up. Blood pressure will also go up in this case. Peripheral pulses are going to be bounding. Neck vein and hand veins are going to be distended. For respiratory rate, you would expect the respiratory rate to go up for both. But for excess, you may see more shortness of breath because they tend to retain fluid in their lungs. So lung sounds are going to be crackles for excess. You will not have that for deficit. And your oxygen saturation for excess, because of the fluid in the lungs, will probably go down. For deficit, it depends on the severity. If the blood volume is so low that your body isn't getting enough oxygen, that'll kick in the increased respiratory rate, which may if that doesn't compensate for the low blood volume, your O2 sats will also go down. Excuse me. Now, of course, your weight is going to go up with excess and down with deficit, as you can lose weight water by losing water. Remember that 1 liter of water is 1 kilogram of body weight. You're going to ask your patients to weigh themselves at the same time of day with the same clothing using the same scale. For skin changes, so with the deficit, remember we said you may have a low-grade fever, so that's going to be warm and dry. For excess, we said that you could be pale and cool feeling. Mucous membranes, of course, should be pink and moist, and for deficit, you're going to see mucous membranes dry and the tongue furrowed. You may see a sticky, gluey, pasty mucus in the mucous membranes for deficit. Skin turgor, if you check on the forehead and over the sternum in the elderly, it's more reliable, but it may tint. For excess, you're going to possibly see swelling, edema in the lower extremities, belly around the eyes, and then again in the lungs, you may hear fluid. Neurological changes, you may see that they have neuromuscular changes where they're weaker. For both of these, you may see it depending on the severity of the imbalance. They may have headaches and visual disturbances, numbness and tingling. Their hand grasp may change. And for both of these, it could be from intracellular swelling or intracellular dehydration. So temperature-wise, again, elevated, slightly elevated with the deficit. Kidney changes, remember, you'd expect to have less volume and more concentrated urine with the deficit and increased output, hopefully, with the excess, more diluted. Lab data, fluid. So the H&H you want to look at, it will possibly be up with deficit because your blood is more concentrated, and down with excess because your blood is more diluted. Urine-specific gravity would be up with deficit because the urine would be more concentrated, and down with excess. Serum osmolality would be more concentrated, so it would be up with deficit, less concentrated with excess, and the same with the glucose, BUN, and creatinine. Electrolytes too. They would just show the hemodilution versus the hemo concentration. Okay, and questions that you would want to ask a patient when you're assessing for hydration status. What their intake and output's been like, what they've been taking in, have they been eating and drinking, what they've been eating and drinking, have they been experiencing diarrhea, vomiting, fever, excess sweating, have they been running a marathon, medication, what are they taking? Have they been experiencing feeling thirsty? Have they been drinking a lot? Have they been exposed to out in the sun? Have they been in high altitudes? Do they have kidney failure or heart failure? Any endocrine diseases that will affect their fluid volume, their kidneys? And if they notice changes in the tightness of their clothes and shoes and rings. So our goals for nursing care for deficit would be to restore their fluid, replace their fluid and electrolytes if there's an imbalance. You would always consider patients' safety because they may have neurological symptoms, and treating the underlying cause of deficit. You would want to offer them fluids every hour. If they're trying to manage their incontinence by not drinking, teach them that that's not really a good solution for them. It's better to use some other interventions for incontinence. Stay with the patient while they drink. Make sure they're not having difficulty swallowing because that's another neurological symptom that can occur. These oral rehydration solutions like Gatorade and Pedialyte are things that we may offer if they're able to swallow and to take fluids. Otherwise, we would give them IV fluids. And depending on what their lab data looks like would determine the IV solution that you'd give them. Fluid volume excess. Again, we want to restore the imbalance of fluid, so we might need to give them something to get rid of the excess fluid. We might need to restrict fluids and in some cases restrict salt. Focus again on their safety because they may have neurological changes. If their kidneys are functioning, we can give them diuretics. Teach if they have a chronic condition, teach them to weigh themselves daily and to monitor for signs and symptoms of changing. Mostly that would be getting short of breath more easily than they had noticed, and the weight changes in their weight. Okay, let's do some questioning. Your patient's blood volume is low due to hemorrhage. What finding would you expect to see? A, increased blood pressure. B, increased heart rate. C, increased weight. D, increased urine output. And the answer is B, increased heart rate. Right? Their blood pressure goes down, their weight goes down, their urine output goes down. Which of these patients on your unit should be observed closely for indications of hypovolemia? The patient who has A, an inability to ask for or obtain fluids, B, kidney failure, C, heart failure, or D,